so Stephanie and I moderated this, and it was great participation, and it was interesting that we really appreciated the patient input, because what we were initially, one thing I was really impressed with, we had both thought of different things before we came to the this breakout session, and what I was impressed with was that the patients really wanted more powerful and convincing studies on the conservative managements, the diet that we recommend, or as we corrected ourselves to say, nutritional advice, and compression and exercise, which we all believed were important treatments for lipedema, but we need larger, more powerful, and convincing studies on these benefits. And then I was also surprised from this meeting. What struck me is how one already approved medication, the DPP-4 medicines that are used to treat diabetes, may be a potential candidate for a medicine to treat lipedema. We're seeing, some studies showing the increased DPP-4 and presence in the lipedema tissue, and that may in the areas of lipedema, but not systemically, and that to me is very interesting. Makes it a very interesting target, and it's a medication that would have other benefits and really is well tolerated, has very few side effects.
So our group one of our goals was sort of to think through if we could design a treatment study, what would that look like? And the group was very effective at designing a study. They wanted a double-blind, 3-arm crossover design study on GLPs, but also on GLPs and conservative treatment, and then conservative treatment only. We had a lot of discussions, right, of the recruitment and retention and the ethical considerations of what does it look like to, offer someone some treatments versus other treatments. And this was a very effective conversation that led us to a lot of really productive conversation. We also sort of narrowed that down at the end. That would be a very optimistic study. So we also thought something potentially that could be, GLPs was sort of what we picked as what we would want to focus on if we could sort of get some good data on something right now. And we thought about what would it look like more near term, a little more feasible. And what we came to was a clinical trial that was still double-blind, a placebo and GLPs, and we wanted to look at some specific outcomes, and the outcomes that seemed to be really consensus-driven to focus on, not just in this study but across the board, would be pain. Quality of life came up a lot. Quality of life is quite broad. The things that stood out most specifically in quality of life that I heard were, pain intersects there, of course, but mobility, and then also social and emotional, and the effect that has on quality of life and productivity, whether that be social productivity, family productivity, work productivity, etc. So those were some of the primary things that I think folks wanted to focus on as sort of the outcomes. And we talked about needing to have, standardized case report form and maybe a 6-month, do follow-up for 6 months. We have also talked about, we had a discussion about where would we tell people to start, and this was from the clinical and the patient perspective. Where would we ask people to start or recommend that patients start if they wanted to start treatment? And this was also there was consensus. The general consensus was exercise, diet, and compression. With education, sort of just education generally about lipedema and treatments being sort of a fourth. And all of those, you can break them down, right? And so that led to some really interesting conversations about diet, ways of eating, nutrition, etc. Also led to a really interesting conversation about exercise and what is, thinking about, do we need more research on exercise, right? What kind of exercise is really helpful? What makes the most impact? We talked about muscle mass and kind of muscle mass plateau and what it would look like to study that. And conversely, we also had a conversation on, is really just the best exercise the one that people are going to do, right? And looking at it from a behavioral modification standpoint. So it was a very productive conversation. We covered a lot of ground, and we have a study design that we might want to look into. So, thank you.